Good evening. Hi, I'm Dan Benjamin. I'm the president of the American Academy, and I'm delighted to welcome you to tonight's lecture entitled Leadership Lessons from a Career in Public Health, which will be delivered by Rochelle Walensky, this semester's Bayer Fellow in Health and Biotech. So just a word or two about the fellowship. The Bayer Fellowship in Health and Biotech was initiated in 2021 with very generous support by Bayer AG, and the fellowship contributes to the transatlantic exchange on innovation in the fields of health and biotech and supports dialogue across an array of disciplines with leading figures from academia and research, from the corporate world, politics, and the public sector. And this fellowship has been a tremendous boon for the Academy and has brought a series of extraordinary individuals here and enriched the discussion under our roof beyond measure. It's also obviously taken us into areas where an institution that was largely dedicated to the humanities, the arts, and the social sciences had not been before. And anyway, I'd like to thank my good friend Oliver Renner and Bayer AG, not only for generously sponsoring this fellowship and making tonight's event possible, but for being a true, if you'll pardon the expression, long marcher for the Academy. I'm not suggesting in any way, Oliver, that you're a Maoist, but just that you have been an extraordinary friend to the Academy for now more than 20 years, which is really something. The Academy, and I mean this from the bottom of my heart, has very few friends as devoted and supportive as Oliver and Bayer. And I also want to thank you for hosting us on Tuesday at Bayer headquarters in Wedding and inviting Rochelle to give a talk to the Bayer staff. And she's told me that the talk has changed dramatically since then. So you too will get to hear something new tonight. And if you don't mention it. Anyway, our Bayer Fellows routinely attract a fantastic set of guests here who also add so much to this discussion. And I'd like to particularly welcome Ottmar Wiesler, president of the Helmholtz Association, who's here, from whom I always learn a tremendous amount. Unfortunately, he had to leave, but Lothar Wieler was here earlier, the former president of Robert Koch, and now professor for digital global public health at the Hasso-Plattner Institute. And I am imagining that the two of you were sharing war stories because he had a really rough pandemic as well. Anyway, one of the really remarkable things that I think many of us learned during the most recent pandemic is that the most famous pandemic before, the Spanish flu of the early last century, left remarkably little record, few marks on our culture. And everyone really wanted to move on and to forget. And after the trauma of COVID, I think we can understand why. But when we think back to when this fellowship began, we were enduring one variant after another, massive public upheaval, a torrent of mistrust, overwhelmed hospitals, crises of all kinds. But we also experienced the rapid introduction of a new family of vaccines that brought the epidemic under control. And for those of us, of course, who were living through it from a subjective point of view, that seemed to be coming slowly. But from a historic point of view, it came with miraculous rapidity. And it's unlike anything in all of human history. The experiences of that time taught us so many lessons about what was lacking in our public health systems and public understanding, perhaps even more importantly, and in policy and international cooperation. And we have been enormously fortunate here that our lineup of Bayer Fellows have addressed so many of these issues. Harold Coe was the former Assistant U.S. Secretary of Health for Public Health, and he was our first Bayer Fellow. And that was an extraordinary stroke of good fortune to have him here at that time. Harvey Feinberg, who is now president of the Gordon and Betty Moore Foundation, who had been the former dean of the Harvard School of Public Health, and his wife, Mary Wilson, a clinical professor of epidemiology and biostatistics at UCSF, San Francisco, were here after that. Albert Hoffman, head of the Department of Epidemiology, also from the Harvard School of Public Health, the T.H. Chan School. It's just been a remarkable array of people who we've had here. Everyone remembers that famous description from C.P. Snow, who said way back in 1959 that our society had two cultures, one of the humanities, one of the sciences. A little worried about the one of the humanities in particular these days, but and he identified back then that they were growing apart, and this was a chasm that the society had to deal with. But I really feel like through this fellowship, the Academy is doing something to bridge that gap. Anyway, whenever anyone brings up C.P. Snow, myself included, I think not about two cultures, but about two groups of people from my days in college, one of whom had those four-color pens. Do you all remember those? Did you have those here in Germany? And the others who did not, like me. Our speaker tonight had one of those pens. I am confident. Two. I rest my case. Dr. Rochelle Walensky is a distinguished infectious disease physician scientist. She served as the 19th director of the Centers for Disease Control and Prevention. She earned her bachelor's in biochemistry and molecular biology, you can hear the click, from Washington University in St. Louis, her MD from Johns Hopkins, and an MPH from, of all places, the Harvard Chan School of Public Health. She completed her residency at Johns Hopkins and an infectious disease fellowship at Massachusetts General and at the Brigham and Women's Hospital. How could you be in both at once? Okay. She has been on the faculty of Harvard Medical School since 2001 and became a professor of medicine in 2012. It's all my father ever wanted me to do. I didn't. Anyway, her research focuses on infectious diseases and HIV/AIDS policy, and particularly on cost-effective strategies for HIV screening, treatment, and prevention in the US and around the world. From 2017 to 2020, she served as chief of the Division of Infectious Diseases at Mass General, where she played a critical role on the front lines of the COVID-19 pandemic. On December 7th, a day that will live in infamy, yes, 2020, she was appointed to serve as CDC director by then President-elect Joe Biden, and there she led the nation's response to the COVID-19 pandemic. There she addressed a really historic, unprecedented, mind-boggling range of infectious disease threats, as well as bureaucratic challenges that probably got a little less attention, but were, I'm sure, as difficult as anything else, and public relations issues also beyond anything we have seen before. During her tenure, she participated in nearly 100 press conferences, and perhaps most painfully of all, provided testimony at 17 congressional hearings, and then made innumerable media appearances in trying to explain to the American people and the world what was going on. Trial by fire, if there ever was one. She was a Hauser leader at Harvard Kennedy School, as well as a senior academic fellow at the Petrie Flom Center at Harvard Law School, a Menschel Fellow at T.H. Chan School of Public Health in 2024, now an American Academy Berlin Prize Fellow, Bayer Health Fellow, a lot of fellows. Currently, Rochelle is an executive fellow at Harvard Business School. Are there any schools at Harvard you're not going to work at? And a senior fellow in the Women in Policy program at the Kennedy School at Harvard, where she conducts research on women's leadership in healthcare. We are especially fond of Rochelle here at the American Academy because she has taken us in her publications where the Academy has never gone before, including 2 articles in just the last month in JAMA, the Journal of the American Medical Association, on the NIH shutdown and the MMR, measles, mumps, rubella, right, vaccine, as well as in the New England Journal of Medicine. We haven't been credited there yet, have we? That's coming? It's under embargo. Okay. Oh, how exciting. The Journal of Infectious Disease, The Lancet, and other publications. In addition to her academic and professional achievements, Rochelle serves on the board of trustees at both the Doris Duke Foundation and the Carter Center for My Money, an institution that could never receive all the praise it deserves. So those of you who spend a lot of time here know that she's married to another Lauren Walensky, who's not here. That was the clicking sign. You got that, right, Pamela? What did you think I was doing? I don't want to know. Never mind. Who is also who's a pediatric oncologist at Dana-Farber, but who could not be here tonight, but is here for much of her fellowship. So we all feel, much healthier and safer under the roof than we ordinarily do. Just by way of housekeeping, Rochelle will speak tonight for about 35 minutes. And then I will pepper her with relevant and irrelevant questions, and you will all be able to ask questions as well. If you're here, you know how to raise your hand, wait for the microphone. And if you're joining online, please type your question in the Q&A part of the platform. Dr. Walensky.
Thank you so much, Dan, for that wonderful introduction. Thank you to the American Academy in Berlin for this incredible experience, to Oliver and Bayer for making it possible for me, and for my incredible group of fellows that I get to share so many meals and wonderful conversations with. I am charged with the task of talking about leadership lessons from a career in infectious diseases, and I thought I would start with why infectious diseases and why a career in infectious diseases. I was a medical student, a first-year medical student in August of 1991, and 2 things happened within several months of my being in medical school. One is the announcement that Magic Johnson, our prized LA Lakers player, had HIV, a new diagnosis of HIV. This made it to the front page of the paper. And several months later, that Arthur Ashe, the tennis legend, had toxoplasmosis and AIDS, and he would soon succumb to that disease. And I knew, even as a first-year medical student, that HIV and AIDS was going to be a big part of my medical training. There was no way around it. If you fast forward just 4 years, I was an intern, a house officer, and this is what the AIDS curve looked like. Everybody we were admitting was dying of AIDS. And everybody that was coming into the emergency room was being admitted and was dying of AIDS. That's a picture at the bedside. That one happens to be at Mass General, but this is what was happening during my internship year until the middle of my internship, December of 1995. And that was a miracle. That was the 3rd drug of the cocktail. And that was when we could finally tell patients that people, if you took 24 to 30 pills, somewhere between 3 and 4 times a day, some with water, some without, some with food, some without, that you might live with this disease. And that was an incredible period of time. This is the pipeline of HIV drugs. I was an intern in 95, 96, and everything on the right in blue were the new HIV drugs that were being developed in the 10 years since I was an intern. It was an incredibly dynamic time, and anybody who was training in this period of time was watching this happen, and I knew that this was going to be my career. There was another problem, though, and that was these drugs were $15,000 a year. And if you knew the kinds of patients that I was admitting, many of them could never afford $15,000 a year to pay for these drugs. And in the Clinton administration, this is now 97, they were working to get these drugs paid for, but ultimately the decisions were that the government had concluded that the plan to pay for these was too costly. And I was taking care of these patients, and they had been stigmatized by their families. Some had been ostracized by their families. They were not allowed to go home. Some of them were storing their meds in homeless shelters, and they're being stolen overnight. And this is what was happening in the front lines. But we knew, and this is what happened to the survival curves in HIV and AIDS during that period of time. Everybody died, and then people lived. And the only people who didn't live were the ones who didn't have access to what we called HAART, highly active antiretroviral therapy over time. Now, I want to give you just a brief snippet of what's happened in antiretroviral therapy since 1995. That's 1995, 30 pills 3 to 4 times a day. By 2015, those drugs are co-formulated into one pill once a day. One pill once a day in the 20 years since I was a health officer. And in 2025, we know that we can give injectables every other month, one shot every other month, and you will be fully suppressed on your HIV meds if you take them. There's another problem. Those drugs today are somewhere between $40,000 and $50,000 per year. And it made me angry that I was at the bedside treating people, and yet I could not get them the drugs that they need so that they could be part of those survival curves. And so when I went to the Harvard School of Public Health to get my master's degree, a lot of what I wanted to do was address this issue. So I embarked on a field of decision science, decision-making in health and medicine. This is the classic textbook. It's written by Miriam Hunick and Milt Weinstein. Milt was my research mentor at the time. And chapter 1 of decision-making in health and medicine starts with decision-making in healthcare. And it says, decisions in healthcare can be particularly awkward, involving a complex web of diagnostic and therapeutic uncertainties, patient preferences and values, and costs. And these were the methods that I sought to learn as I was doing quantitative mathematical simulation modeling so that we could take each of these issues into account and build models in order to evaluate cost effectiveness. Now, if you can build a model of disease and you can project out the costs associated with that disease over time, lifetime costs, and you can project out the effectiveness of those interventions over time and have an outcome like years of life saved or quality adjusted years of life saved, then you can start developing what we call cost effectiveness ratios. That is, what is the additional resource use of treatment A versus treatment B divided by the additional health benefits of treatment A versus treatment B. Then we have a cost effectiveness ratio. We know that the lower ratio, is like golf, the lower the ratio, the more cost effective an intervention. We like low ratios, but there's a whole nother science around what are we willing to pay? What are we as a society willing to pay from a cost effectiveness ratio? And this began my career in decision science in HIV. So one of the early papers I wrote was this paper. We projected out the life years gained by these new antiretroviral therapies. This was probably one of the most cited papers of my career in 2006, called The Survival Benefits of AIDS Treatment in the United States. And I love this slide because it's the only one in this deck that's not mine. This slide is Tony Fauci's. And this is the reason that I met Tony, because he loved this paper. Why? He created a press release at the NIH, it was funded by the NIH, that said AIDS drugs have saved 3 million years of life in the United States. And if you could say that statement in front of Congress, then you could in fact start advocating for more and more resources to develop more and better drugs. And he used this in front of Congress for years. I was very sad when he stopped using it, but it became outdated. But he used it for years. I also became very frustrated with the HIV screening guidelines. So we knew at the time that a third of people in the United States who had HIV did not know they had HIV. And that many of the future infections, the transmissions that were happening, 2/3 of them in the country were from people who didn't know they had HIV, and so they were just passing it along. And we thought, well, we really should be doing routine HIV screening in the United States. This was one of the papers written in 2005 that looked at the cost effectiveness of routine HIV screening in the United States. The cost for that test, by the way, is $1. It was the stigma that was getting in the way. And we demonstrated the value of routine HIV screening in the United States. And this, among many other things that were happening at the time, is what changed the HIV screening guidelines at the CDC, such that now we recommend routine screening for all inpatients in all hospitals in the country. It's not routinely done, but any patient who was on my clinical service, I always asked if they would get an HIV test to rule out HIV infection. Because we could use these models to not just project life expectancy and cost effectiveness, we could use them to project lifetime costs. One would say, well, why do you really need to know the lifetime cost of care? But these drugs are $40,000 a year. And this was really valuable in a way I didn't expect. In 2009, the Obama administration was trying to reverse the immigration ban of HIV-infected persons who were coming into the United States. For years, since 1993, people with HIV were not allowed to come into the United States. And as they were working on this new law to reverse that immigration ban, they came to us and said, well, how much is it going to cost to treat them? My first answer was, I know the answer to that, but you never ask for anyone else. And my second was $300,000 a year. Here's the paper. It was written into the law. And for the first time in decades, the World AIDS meeting was invited back to the United States in 2012. I happened to have been on the planning committee, and the Obama administration welcomed us to the White House when the World AIDS meeting came back to the States. I've done a lot of work in HIV prevention as well. I told you that those HIV treatment drugs were $40,000 a year. The prevention drugs are about $25,000 a year. And the thing that is so frustrating is that those exact same drugs are $60 to $7 a year in Africa. And so that has been a big access problem. The drug costs have been a big access problem for the highest risk patients. And I was asked in May of 2019 to go in front of Congress for the first time, where I did not know where my career was headed. And this was advocating to decrease the HIV drug costs so that the prevention could be more accessible to people around the country. I will mention that one thing that is also true about decision scientists is that we learn how to manage and address uncertainty. And it turns out that chapter 2 of the Hunick-Weinstein book is actually called Managing Uncertainty. So I'm actually trained in this, believe it or not. That chapter starts with, much of clinical medicine and healthcare involves uncertainties, some reducible, some irreducible, despite our best efforts and tests. Better decisions will be made if we're open and honest about these uncertainties and can develop skills in estimating, communicating, and working with some uncertainties. They teach you how to actually do this. So fast forward to the summer of 2020, I've been invited to work on Governor Baker. He's our governor of Massachusetts, or was our governor of Massachusetts, his reopening board, if you will. Now, this was before vaccines, and we were talking about how we were going to reopen a very blue state of Massachusetts. Now, if you sit on this governor's reopening board, especially in Massachusetts, you are surrounded by a lot of people who are college presidents. And all of them want their colleges opened in the fall. So many of them came to me and said, what should we be asking? 6 feet, 3 feet? What should we be doing? What should the protocols be such that we can get our colleges reopened? And I thought, well, we can model that, right? We knew that symptom-based testing was not going to be enough because people were transmitting before they had symptoms. But we did have this PCR test. We had this screening test. And we said, well, we should be able to model what frequency of PCR screening we needed to do in order to be able to safely open the schools. And we were able to model that. One of the interesting things is that isolation capacity turned out to be one of the biggest issues. That is, if you're going to test people a lot, some of them are going to be false positive, and you need to have a place to put them because you can't keep them in their, triple room. And so we actually demonstrated that screening every 2 to every 3 days using a PCR test was the best way to get our colleges open. And that is how all of Northeastern United States got our kids back to school. In fact, people were scaling up the testing capacity like wild because this is how kids got back to college for that first year before they had access to a vaccine. So then I get this phone call completely out of the blue from Ron Klain, who I then Googled to make sure I knew exactly who it was, and asking if I would consider serving as the 19th director of the Centers for Disease Control and Prevention. There are many a story that I could go into there, but for the purposes of time, I will just say that the CDC director at the time was not a Senate-confirmed position. That has changed in the politicization of the agency over the last several years. But I was sworn in on January 20th, hours after the president, in my living room. That's my living room. I'm on a Zoom, and that's where my swearing in ceremony. And I look very happy there. I do know that I have a lot of big challenges ahead, but this is really the challenge that I had ahead. And that was, this is the death graph of what was happening in COVID at the time. I put a red line at the date that I was sworn in, and people were dying at 3,500 per day due to COVID-19. And that was the work that I had ahead of me. Now, I don't want to spend a lot of time talking about COVID, and we can have all sorts of conversations about masks, schools, and aerosols, which are all my favorite topics. But what I would really just like to remind people in this room and people who are part of this in Germany and really around the world was there was a huge amount of work done. Under my tenure, we put 670 million vaccinations into arms at a time and an effort that has never been paralleled. And I do want to just acknowledge the people, some of whom are in this room, who did a lot of that work in solidarity with people around the world. And it saved lives. This is a modeling analysis that was done by the folks at the Commonwealth Fund. The gray line is the estimated counterfactual in the absence of vaccines. But it is estimated that those vaccines averted somewhere around 2.2 million deaths, 17 million hospitalizations, 66 million infections, and about 900 billion in healthcare costs. And I think that was an extraordinary feat. But I don't want to spend much time talking about COVID because you have read all about that in the headlines. And what I really want to do, especially in these sort of challenging times and moments, is talk about some of the really fun stories you might not have heard. So one of them is, this is going to be Days in the Life as a CDC Director, Stories Untold. Now, I couldn't get away very much in the early days of my tenure, but they did let me leave the country finally in July of 2022. And when I left the country, I went first to Zanzibar, Tanzania. This is the CDC country office in Zanzibar, Tanzania. And there are country offices like this, probably a little bit smaller, around the world, 60 of them around the world, just to give you a sense of the footprint of CDC work. And their office was so beautiful that they each had their own outfit made in a specific kind of a katanga for my arrival. From the country office in Zanzibar, I went with our country leader, Mahesh Swaminathan, to our HIV treatment site in a very rural space where people who would otherwise not have had access in collaboration with PEPFAR and USAID got their HIV meds. And from that clinic, that clinic, which you see has sandy ground under it, we went to the hospital where this doctor showed me around not only to the HIV inpatient ward, but also to the methadone treatment center. And that is the work that people are doing right now, trying to do right now with CDC. One of the great things that I got to do after Tanzania was go to Uganda. And in Uganda, I went to a DREAMS site. DREAM stands for Determined, Resilient, Empowered, AIDS-Free, Mentored, and Safe. DREAMS is a program in collaboration with PEPFAR and USAID that takes these young girls between the ages of 10 and 14 off the streets. They are otherwise at very high risk both of pregnancy and of HIV, and they teach them a trade. They teach them how, in this picture, these girls were taught how to sew. They sewed their own skirts. They made their own masks for me. Every girl that goes through a DREAM site has to do two other things. One, they learn finance. That's what you see on the right. They are learning about income. They are learning about currency. They are learning about empowerment and what they can do with their money. There's one other thing that they learn, and that is how to use their voice. So most of these girls have never, ever, ever raised their voice. They didn't even know they could raise their voice. And they have been completely disempowered in some societies where men are taught that the only way to get rid of their own HIV is to have sex with a virgin. This is what happens at those dream sites. It was incredibly empowering to be there and to learn what these girls are now doing. Some of them are already moms, but learns what they are doing so that they can work very hard to stay HIV free. So I left the dream site in Uganda and I went to Kasese, Uganda, right on the border of DRC. And you can see actually DRC across the river with the mountain behind me. And this is border control between DRC and Uganda. I see so many familiar faces that are nodding their head. It makes me so happy. Where we are learning, where CDC employees are teaching folks on the ground about field epidemiology, about screening for viral hemorrhagic fevers. So this gentleman on the right had been part of that workforce that had been taught. And I heard this story about him. He had seen on WhatsApp that there was a woman and her 4-month-old baby who had escaped an Ebola treatment center in Congo and was trying to get across to Uganda. He actually identified this mom and baby and brought her to that isolation unit and in Kasese and probably saved the country in an Ebola outbreak, who knows how large. From there, I went here, Zika Forest, all right? And in Zika Forest, the Zika Forest is a fascinating place. So you go into the forest and you see these ladders. And on those ladders, it turns out mosquitoes travel at different altitudes. And so they trap the mosquitoes at each of these different altitudes because they're different mosquitoes and they're carrying different things. And they take those mosquitoes and they take them out of the forest. This is sitting right outside. And these gentlemen are freezing them in liquid nitrogen and then bringing them to UVRI, the Uganda Viral Research Institute. And at UVRI, they're doing all the disease detection in those mosquitoes and detecting new and novel viral hemorrhagic fevers such that that's the rate of viral hemorrhagic fevers in 2010. And that's where we are now in 2019 or 2020, the last time they updated the graph. That's the work of what public health does for you. So that was like my little international trip to Tanzania and Uganda. But I thought I would tell you a couple of other stories. This was one of my favorites, partially because they got me. So this is a story about melioidosis. I'm guessing most of you have never heard of Burkholderia pseudomallii. I had seen one case in my career. This is a bug that lives in the soil, but it doesn't live in United States soil generally. It lives in the soil in Far East Asia, India, Thailand. We very rarely have cases in the United States, and when we do, it is because it lives dormant in humans and it recrudesces somewhat like, I see ID people nodding their heads, somewhat like tuberculosis. So when we see these cases in the United States, they generally are in people who've lived abroad and then come back to the United States as an elderly person and end up with melioidosis. So in March of 2021, we're all focused on COVID, and there's a call that a 53-year-old woman who comes in really sick, she had previously had some lung disease, ends up with Burkholderia pseudomallii positive in her blood cultures, and she ultimately dies from this. I was not told about that case. I was told about the subsequent 2 cases. The next one, and she was from Kansas. She had never traveled. She had never gone anywhere. She had never been to any of these endemic regions. And she dies of melioidosis. In May, 2 months later, a 4-year-old girl from Texas comes in and she has melioidosis in her sputum. She becomes previously healthy, neurologically devastated, and she had never met the woman from Kansas. She had never traveled like the woman from Kansas, and they had never met one another. And then a month later, we have another case in Minnesota. So this woman is a 53-year-old woman. She cultures melioidosis from her blood and her hip joint, actually. And now they're starting to say, oh my God, what is happening here? We shouldn't be seeing this. They start isolating the organisms. They get the organisms from all these different sites, and they sequence the organisms, and they realize it's the exact same bug. And I'm thinking to myself, there is no way these people are going to find out what this is, right? How are they going to figure this out? July comes, fourth case. It's a 5-year-old boy. He's from Georgia. And he presents with lung abscess and brain abscess, and he ultimately dies of the disease. They again sequence his organism, and it is exactly the same bug. None of these people had ever traveled. None of these people had ever known each other or been in contact with each other. And I am thinking, how are they going to figure this out? And this is the best work of public health. And this is your answer. This Better Homes and Gardens lavender chamomile aerosol spray was found in every single one of these households. It was cultured and had the same Burkholderia pseudomallei that was found in every single one of those patients, and it was taken off the shelf. Right? That's what public health does. One more story in the life of a CDC director, and that is Sunday, August 29th. I'm in Los Angeles, and my intent was to spend the weekend helping my kid move into college. Turns out the administration had other plans for me, and that was that it was booster weekend. That was the weekend we were all going to talk about whether, if, how, who should get boosters in the following season. So I've spent my entire weekend on the phone talking about boosters, and I get this phone call from the Deputy Secretary, Andrea Palm. And she calls me to tell me that there's going to be an emergent mission to evacuate and safely resettle 72,000 Afghan evacuees. This was Operations Allies Welcome, for those of you who recall. It was coordinated by the State Department and the Defense Department. And the DepSec was calling me to say, we're a little bit worried about COVID. And I was like, you have a lot of other things to worry about. So let me tell you what happened. So first of all, just to know, the State Department in the United States have medical requirements for immigration into the United States. You have to document your vaccination records. That includes MMR, measles, mumps, and rubella, polio, tetanus, diphtheria, pertussis, Hep A and B, and many others. PPD status, that's your tuberculosis status, has to be documented, as well as your syphilis testing status, and you have to have proof of treatment if either of those are positive, medical history, hospitalizations, mental illness, and disability status, and a physical exam. So needless to say, 73,000 people were not going to have all of this by the time they showed up in the United States. Just to give you a sense of what's going on in the background in Afghanistan, Afghanistan is one of the two countries where we still have endemic wild-type polio, Pakistan being the second. Oral polio vaccination rate is about, for all 3 doses, is about 71%. And between January and November of 2021, guess what? They had an active measles outbreak. And they had nearly 26,000 cases of measles in Afghanistan as these folks were about to come to the United States, where the measles vaccination rate was for 1 dose about 66%, and for 2 doses about 43%. So remember, the DepSec called me on August 29th, and by September 4th, we had our first case of measles in the United States. It took about 5 days. And that case was identified in Fort McCoy, Wisconsin. And by 10 days later, we had another 5 cases of measles. And that was in Fort Pickett, Virginia. Now, if you think that we're doing anything close to quarantine here, this is what some of those evacuation sites looked like. And then I get this phone call, Walensky, what do you want to do? And I was like, what are you going to do, contact tracing on this? So I made the probably most unpopular decision. I made a lot of unpopular decisions, but one of them, the State Department and the Defense Department were not happy with this decision. But the only way to deal with measles in this is to say 21 days of quarantine and vaccinate everyone. 72,000 people. So we did. They were not happy, but we did. Massive efforts to isolate, identify, quarantine, mass vaccinate, and we got 96% coverage. Prior vaccination status was, of course, unknown. We required 21 days of quarantine after the MMR receipt. And among the 72,299 evacuees, 47 cases of measles occurred. and none of them got in the community. They were all among the evacuees. We also, of course, had active cases of mumps and syphilis and TB and rubella, and I can keep going on. And we did have some COVID and some influenza. Which brings me to measles, because I had to somehow get to measles. This is the measles, the MMR vaccination map in the United States in 2023-24. To be over 95%, which is what we need for herd immunity for measles, you need these maps to be green. That's over 95%. The blue states are between 90 and 95%, and those darkest states are now under 90% vaccination coverage. Very sadly, I will tell you that this is what the map looked like before the COVID-19 pandemic. So we have had a distinct sliding back of MMR vaccination coverage since the COVID-19 pandemic. I've done a little bit of reading as to how things are going here in Germany. Yes, in fact, your far right, like our far right, has not been big proponents of the vaccine. This was a paper that was published in Vaccines that actually demonstrated that you haven't had as much, at least, of the negative slide that we did after the COVID-19 pandemic, although I would defer to other experts in the room to see what they're really seeing on the ground. Now, I want to play a little epidemiology game, because that's what I do. I'd love to sort of have this thought process for you to just get a sense of why we in infectious disease fear the measles. So let's pretend, and I hope may this not happen, that you develop a rash tomorrow. And that rash, you might have had a little bit of prodrome, didn't feel 100% today or yesterday, but you kind of ignored it and thought it would go away. And tomorrow you develop a rash. And now I'm charged with doing your outbreak investigation. So my question to you is, where were you last Friday? Day -7. So that's right. Does this work? Day -7. And I would ask you, where were you not only day -7, but where were you every day for the 2 weeks prior to last Friday? And I not only want to know where you were, but I want to know in all the places that you have been, who was there 2 hours before you? That is the people who might have exposed you. Okay, now the question is, who have you exposed because you now have a rash? And you're infectious from day -4, the day of your rash, until now. So I want to know every place you've been since Monday. And I want to know all the people you might have interacted with between Friday and Monday. And not only the people who were there, but the people who might have been there 2 hours after you left. That's your measles outbreak investigation. Our last big measles outbreak in the United States happened in 2018, 2019, interestingly, under the same president that is the current president in the United States. This is an epidemiologic curve. You guys in epi know this all the time. Each tick on the horizontal axis is a week. And this is what happened in New York in 2018 and 2019 in an Orthodox community, an under-vaccinated Orthodox community. The number of people in this outbreak ultimately was 649 and 2 deaths. This was published in the New England Journal of Medicine. What you can see in this epi curve is each week there's a bar graph of new cases that are identified. And the color of those graphs are the neighborhoods in which those are identified. To control this outbreak, which lasted almost a year, the New York Department of Health and Mental Hygiene had to hire 559 staff in order to do contact investigations, like I just talked about, for over 20,000 people. In doing so, they identified exposures of over 1,000 for babies who were unvaccinated and less than 1 year old, 400 pregnant women, 100 immunocompromised persons. I already raised the fact that there were no deaths in this investigation. It cost $8.4 million to do that. And the New York Department of Health and Mental Hygiene required vaccination. I'm told that was under risk of fine of up to $1,000 if it was not done. And it was upheld by the Supreme Court of Kings County. That's what happened in New York. Oops. Here's where we are in this investigation on the time horizon. We're 8 weeks in from our first measles case in Gaines, Texas. 8 weeks in, they were at 35 cases, if you tally that. Okay? We are at 296 cases. This is the map. We have had 2 deaths. Remember, that investigation had none. We also know that there is likely substantial underreporting. So why is that? Because we know the death ratio for measles is about 1 in 1,000, which means we probably have around 2,000 cases, statistically speaking, and we're only reporting about 296. We know that the people who are coming in are presenting late, if at all. In fact, one of those deaths did not even present to the hospital. We know that the people have been resistant to epidemiologic investigations, and that the population size, we're not only talking about challenges with the numerator, but the denominator, the population size, we don't necessarily believe is stable as well. The census figures may not be reflecting everybody in the population. So more to be told on this measles investigation, but I just want to give you a sense of why we in infectious disease are so very worried about it. One slide on the state of science. Dan mentioned the first paper that the doctors Walensky have ever published together happened because we were here together at the Academy. We were speaking over dinner and lamenting the challenges that we had, and we started looking at some of the data. These are the data from 2 of the largest institutes at NIH, NCI, National Cancer Institute, and National Institute of Allergy and Infectious Diseases. There is a 10 percentile funding rate. That means you have to submit 10 grants in order to get 1. This is 2024. It's also the case that you can only ask for a certain amount on a scientific grant, and that peak amount is $500,000 a year. But that amount hasn't been changed since 1993, which means the buying power of $500,000 is down 57% since the last time they increased that peak. One of the big issues in science is the age of your first R01. So R01s is your big independent NIH award. At Harvard and in many other places, you need to have an R01 before you're ever considered for an associate professor position. The main age of the first R01 in the United States is now 43 years old for PhDs and 46 for MDs or MD PhDs. And this just gives you a sense, this graph on the right, of where we are in terms of getting even funded, even scientifically viable grants out the door. If you look at where that dark red line is, that is today. If you look at those grants that have been funded in years past, we are about 7,300 grants are behind in getting out the door to scientists who've already had their science approved, and that's about $3.5 billion behind. That is before we talk about hiring freezes and indirect costs and all the other challenges that are on our plate. Even fundable grants with fundable scores are not getting out the door to our scientists. I can't leave you on that note because I'm a generally optimistic person. So I want to spend just the last few minutes talking about ways you get to make a difference if you get to be in the hot seat. And I was in the hot seat, so I was going to use that hot seat to make a difference. So I'm going to tell you a little story about a patient, Mr. V. Mr. V was a gentleman from Thailand, and he had rheumatoid arthritis. He got an immunomodulator, and if you listen to those commercials, you hear about all the risks. But this gentleman, unfortunately, had metastatic tuberculosis, and I was called to see him. He had TB everywhere, including his joints, including his liver. And Dr. Robbie Goldstein and I went to see him together. Robbie was a dear colleague. He was my fellow. I was the attending of record, and we saw him every day for weeks. And we did everything that we could to save Mr. V, and Mr. V passed away. And it was really hard for both of us. And one of the things I tend to do, and it's easy to do if you work in a hospital, is when those kinds of things happen, I tend to go give blood. That's like put some good in the world. So I went to Robbie and I said, hey, let's go give blood and just feel good about the events of today in some way, shape, or form. And Robbie, to my astonishment, because I should have known this, said, I can't. I'm a gay man. 2016. And I thought, well, that's a crazy policy, right? In 2016, that gay men still can't give blood in this country with all of our drugs and all of our screening and all of our capacity. And so I went and I gave blood, and that's Robbie Goldstein on the right there. A few months later, we had the Pulse, the Orlando shooting in the Pulse nightclub, 49 deaths, 53 wounded, and gay men signed up to give blood. And guess what? They couldn't. And so Robbie and I and our friend Hannah Sachs, she happened to have been the attending of record on Mr. V, decided to write about it and we said, one day, we don't know how, we don't know when, we're going to address this and fix it. So it turns out I got to be CDC director, and I asked Robbie, and he took an incredible leap of faith and followed me and became my senior policy advisor. He's now the commissioner of the public health in the state of Massachusetts. But he and I worked together for years during the COVID pandemic, and we worked with the FDA and the Office of the Secretary of Health so that we could reverse the ban on blood donation among men who have sex with men. This is the announcement and the guidance document from the FDA and some press that covered it. And sure enough, in August of 2023, Robbie and I gave blood together. And those are the things that you get to do if you also have to take some of the hot seat. So I'm going to close by just my final leadership lesson, if you will, and that is I learned that people matter. Now, that seems obvious, people matter, right? But this was probably the easiest slide I could put together. There are all sorts of these things. I look particularly awful in some of them. I'm a vaccine witch. I have a credibility problem, all sorts of challenges. This one, my son sent to me, I swear I didn't say this, but this is our satirical magazine in the United States. My son sent that one to me. But when you have some of these particularly awful days, it matters how people treat you. And when you come home after some of those particularly awful days, and a third grader who got her COVID vaccine bakes you a cake, or you show up after a hearing and Rochelle Rocks shows up on your doorstep, you start to realize how very much it matters. And I have done, one of the things I did at CDC after sort of getting some of these was I made what I called unsung hero calls. I asked the team to put together the names of 5 people every week who I would never otherwise have called or spoken with, who went above and beyond that day or that week. I talked to somebody who rappelled out of a helicopter to drop test kits on the Diamond Princess cruise ship. And I talked to somebody who went door to door and did health surveillance after the Ohio train derailment. And I talked to the woman who booked the flights for all of our vaccinators in Operations Allies Welcome because they had to leave in the middle of the night to deploy. So these were the people that I sort of said, well, if somebody's going to make me Rochelle Rocks, I'm going to make some phone calls. And it was really, I had so much more fun doing it than I'm sure they had receiving it, but it was really quite a virtuous cycle. So this is a this is a colleague of mine from MGH. These are her kids for Halloween. If you can't recognize us, that's me and Tony Fauci. And I sent this to Tony. I texted it to Tony, there's in his NIH little ID, and I said, what do you think? And he said, I think they got the height right. So with that, I will close and say the most common question I get is, would I do it all again? And it was actually day on December 8th, not December 7th. The answer is what I said at my nomination speech, which was, I never anticipated I would take on a role leading our nation's response and government service was never part of my plan. But every doctor knows that when a patient is coding, your plans don't matter. You answer the code. And when the nation is coding, if you're called to serve, you serve. You run to take care of people, to stop the bleeding, to stabilize, to give hope, to give them hope and a fighting chance to come back stronger, because that's what doctors do. I'm honored to work with an administration that understands that leading with science is the only way to deliver breakthroughs, to deliver hope, and to bring our nation back to full strength. So as I close, I just want to express my profound gratitude for the privilege of being here among such extraordinary minds. Really, in this room, that I get to dine with every day. They're luminaries spanning humanities and deep thinkers whose insights right now are more vital than ever. We gather at a historical moment when norms and traditions are being upended, when uncertainty challenges us to think more critically, act more boldly, and engage more meaningfully. So in this extraordinary space of warmth and beauty and intellect, I have found not only inspiration, but also a shared mission and purpose. My deepest thanks to the Academy and to Bayer for their vision and dedication in creating this remarkable fellowship experience, and to all of my co-fellows for the conversations and the reflections and the friendships that I hope will endure long beyond our time here. I'm really honored. Thank you.
That was a great talk. And a damn good-looking family, I have to say. And I think from now on, all fellows should be required to have slides like that at the end, or if other people they love, whatever. I'm just curious. Those CDC posts around the world, have they been shut down, otherwise interfered with? Do you know?
I don't know the answer to that. I imagine they're still pretty operational right now. That I also imagine they may well be a target, but I don't know. I don't definitively know the answer to that. But we work. I mean, the agency works collaboratively in so many different areas and spaces with the State Department and the embassy. And I will say that during my tenure, when I got to do some of that international travel, I heard loud and clear how important America was in the COVID response around the world just by virtue of CDC presence there. So that was actually really wonderful to hear.
So the reason I ask is pretty obvious. And, we've gone through an earthquake. Earth's still shaking. We heard a lot of it from Jeff the other night. I imagine you spend a lot of time wondering how it is that we got to a place where we are no longer leading with science, or seem to be kind of at war with science, at war with the institutions that promote science, that deepen our understanding of the world, and so on and so forth. And you undoubtedly had to deal with all kinds of manifestations of anti-vax sentiment and all the other nonsense that you had to hear when you were testifying. And I'm just wondering what kind of sense you make of the kind of anti-science moment.
Yeah, I mean, there are certainly people who are anti-science. I really want to, and truly anti-vax. I prefer to focus my time and energy on the places where we might actually meet in the middle. I once had somebody who was a social worker teach me how to give an HIV diagnosis. And the thing that she used to teach me was the first thing you say is your test came back positive, you have HIV. And then you stop talking altogether. And it's like a painfully long silence before somebody else the patient will say something. But when that patient talks, you hear the things that are most important to them. Is it, am I going to die? How am I going to afford my meds? Where did I get this? Will I lose my job? All the things. And this was back, of course, in the early 90s. But I think I treat sort of the vaccination discussion that way too, is I had so many people who had very reasonable reasons and concerns for the vaccine. And if they had actually had more opportunity, so many people said, how do you convince somebody to get vaccinated? And the answer is you stop talking and you listen to what their concerns are, because you can't make up their concerns. You have to, I met with somebody who had gotten Guillain-Barré, which is a pretty severe side effect from the influenza vaccine. Well, that's reasonable that she'd want to have a little bit more information from this mRNA, or she might not want to be the first in line. Sometimes it's you just have to talk to them every day. I met with somebody in the Los Angeles Department of Public Health who had a mission to like make sure that the people in his in the convenience store on his way to work would get vaccinated. And he would stop in there every single day. And after like a month, they're like, all right, finally, so it takes some time. People need information. They need, so I think some of this we're calling anti-vax is actually just not anti-vax. It is like, I need a little bit more time. I need to see how this is going. There was a really wonderful piece in the New York Times by Caitlin Rivers out of Hopkins, where she talks about, as challenging as those measles maps were, I will say that 93% of America is vaccinated. 93%. And I would challenge you to find anything in America that 93% of people agree on. Right? So like vaccines is one of, it might not be 95% where we need it to be, but it's still pretty high. The other thing I sort of talk about is public health works in ways that we depend on until we, and so we talk about sort of the challenges in anti-vax, but there's so much public health that is working. We drink from the tap water every single day, right? So we go out to eat in restaurants. We do so many things that we depend on in public health. And I worry, as there's concerns of it being chiseled away, that we will start realizing very sadly, as we are in Gaines, Texas right now, that we depend on it way more than we realized.
Yeah, the water divide is one of the big ones in the world, and it's just astonishing when you go to one of those countries and you're like, and no leafy vegetables either.
Yeah, exactly.
You should remember that on your upcoming trip, by the way.
Note to self.
Rochelle is off to Chad, and feel free to
no leafy
say
vegetables
what's nice knowing you and that kind of thing. Sorry, I don't want to cause a problem. Well, that's interesting that you, because maybe because I'm a little hysterical about the whole thing, I just am astonished at how anti-science has become a political movement even. I just worry if we have the resources to talk to all those people about why they should get vaccinated. And it's kind of extraordinary how the public debate is.
And I was actually having this conversation earlier today about, the science is a process. It's a learning process. It's not a today is a fact and it will be forever. And so this was really one of the challenges that when I said I was going to lead with science, I said this in my first op-ed when I first joined the administration. I wish I had said, and it will change, and we will learn, and as we do, we will update. That's obvious to scientists. I should have. I didn't realize I needed to say it, but I wish I had said that, because science is the process of gaining knowledge. And as you gain knowledge, you ask more questions. And as you ask more questions arise. So, and you have to update your priors. You have to update your actions.
Yeah, that was one of the really extraordinary things about the pandemic, was the intolerance of the public for advances in knowledge. The all-time great example being guidance on masks. It changed, and therefore the whole public health establishment was somehow delegitimated.
Yes, I felt that.
Yeah.
When we took masks off in May of 2020, and I've thought a lot about were any of the decisions that we made under uncertainty with the sort of priors that we had the wrong decisions. And I think given the information at the time, we had some of these, and I'm talking at the micro, not at the macro. Many of them were sort of right in the moment, and they failed on execution in communications or in implementation, or, our intent was following the science or the information that we had. And it was hard to articulate and hard to get. The United States is 3,300 counties. We had guidances that were for New York City and rural Idaho and Indian country and Alaska and Hawaii. We were trying to, have a one size fits all for all those very different places.
Yeah. I'm going to ask a question. I hope you won't hate me for it.
Awesome.
And it just came into my brain, so I'm probably not doing due diligence on it. But when pollsters would talk about some of the problems that Biden had going into the election, they blame Afghanistan, and then they blame him declaring that the pandemic was over. And I was curious if you want to talk about that moment and that decision, and you can say, I'm just not talking about that, and I'll rip your throat out if you insist.
The pandemic was over in the summer of 2021.
Yeah, no, in 22, I thought it was.
Well, there was a July 4th celebration in the summer of 2021.
Okay.
No, you're right. It was the summer of 2022. Yeah. I think the real challenge is, again, this is communication, right? When do you know? I compare this. My husband's an oncologist. When do you know that your cancer didn't come back? When you die of something else, right? When do you know that the pandemic is over? When you don't have another surge. But everybody wants to say, is it over? Is it over? And so it's a very hard thing to try and articulate, right? We probably have endemic COVID at this point, but to have people demanding and saying, so, right, today's the end date, that's not how it works. But that's what public demanded.
And what keeps you awake at night now on public health?
Nothing. I look out at the Fonzie.
We're just emphasizing the positive here.
Yeah, I know. Pandemic preparedness keeps me up. Everyone thought 100 years after the 1918 flu that we would have another pandemic, and everyone thought it would be influenza. And we got COVID. And that doesn't protect us from influenza. And we have an avian flu that's knocking at our doors, especially in the United States. And we have made a huge amount of progress in certain ways in our public health systems. Our data systems are better, although not nearly where they need to be. But we have lost ground in confidence and in workforce and in morale. And now in the challenges that are this administration is putting forth in the space of health, public health, and science. And I just don't think that is going to serve us well if and when we have another outbreak. It's pretty well documented that zoonotic infections at the human-animal interface, that 75% of new and novel infections are zoonotic infections at that human-animal interface. So in addition to the challenges of influenza, there could very well be others. I also worry a lot about the frail public health infrastructure that we have, and that I thought would get a huge bolus. I think I've done the math once before. We lost 1.2 million souls in the COVID pandemic. We have a public health budget that's at orders of magnitude less than the Defense Department. And the people we lost in COVID are the sum of all people who've been lost in wars combined in America.
Questions? There we go. Gideon. Sorry, Till, you're next.
You're great, Rochelle. We love you. You talked about updating your priors. And I know that when we first heard about the COVID outbreak, you were like, okay, we know how these things start, and they usually start with something coming naturally in the wild. Have you updated your priors? Do you think any differently about the COVID outbreak question now on the basis of the newest evidence than you did in the old days?
I have not been a student of this, and I have actually intentionally not been a student of this because, quite honestly, I had my own challenges, and these fell squarely in other people's camps. What I will say is, increasingly, there's evidence that update my priors that say it wasn't definitively from an animal source. If you look at all prior coronaviruses, we know they come from animal sources. We know MERS was from an animal source. We know SARS-1 was from an animal source. And most infectious disease docs, and if you've ever been to a wet market, like these things can happen from an animal source. So a wet market like the Wuhan market. There have been enough people who have done enough studies that sort of say, could this possibly have been a lab model, a lab leak? I can't definitively say that it wasn't, and I don't think we'll ever have the data to be definitive on that. And so it feels like we're, I sort of feel like it's one of those finger toys. I was talking about this a little earlier. Those kids' finger toys where the further you pull, the tighter it gets. We keep pulling on this, and so we just keep strangulating ourselves rather than coming closer to the middle where we can breathe again and start having further conversations.
So Till, you had a question, right? And then come up here.
Yeah, wonderful privilege to learn from you, Rochelle, as always, and these insights into a day in the life, what leadership opportunity and growth opportunity, and where do you want to go next? That is my first question, but then two concerns and deeper questions, less personal. So one is the HIV pandemic is, of course, an African pandemic mostly, and it is happening right now as we speak. We just estimated what the PEPFAR freeze, the waivers have been implemented very sparsely and wrongly and in confused manners. Nurses have already been let go. Now we have the money again, but you can't rehire the nurse because she doesn't trust you anymore. She has a new job in the public sector. So we estimated now, even in the first 3 months of the PEPFAR freeze, probably in 7 countries where we had a microsimulation model that was up-to-date, calibrated. We had the PEPFAR data, how much PEPFAR is in there in the HIV response, 40,000 deaths. That's our sort of most realistic scenario, up to 80,000, down to 20,000, that range. Similar amounts of HIV infections that could have been averted, and the pandemic is coming back as we speak. It's so rapid, right? People are very quickly again in the dying situations that you showed in the 90s. And the third question now, that's in Africa, and shouldn't we be even more alarmed and have even more voice? I'm a little bit shocked and surprised how little voice many US colleagues seem to have, because they're so fearful. And we wrote pieces and had on 2 authors withdrawing in the last minute out of fear that they could be hunted down and grants withdrawn. We had to make a change in a big collaborative piece that is coming out now soon on global collaborations in this time, where 3 authors wrote us all the same sentence. We had to take out our introduction because we said something about Trump, and the verbatim sentence that they from different institutions told us why they cannot be on a paper that features that. We in science cannot criticize a sitting administration. Where does that come from, right? They talk to their lawyers and everyone is hugely afraid and fearful. So where's the voice in science for the people who are dying again in Africa, where the United States, in a fantastically successful mission, really moved the world and moved people into near normal life expectancies, not only in the US, but globally. And the last one is in CDC, and you've correctly focused on, no, I really want to know, because it was infectious diseases, and of course there are the traffic accidents, there are the fentanyl, 800,000 plus traffic plus gun violence. You are at similar magnitudes as COVID-19. So, but maybe that's for later. And
you can pick what you want.
I leave
any
the
3 of those 7
for focus, because it's HIV. It's
Yeah,
most important.
I don't have an answer for you except to say how devastating it is to spend 25 years to. I mean, we had so many 3x5 in 2005, 3 million people on antiretroviral therapy. We did all of this. We made so many gains, and what you know is that you're going to let the genie out of the bottle. Infections are going to happen, and then they need. Not only do you need to find them, you need to get them treated. They cost a lifetime of antiretroviral therapy costs at this point. And they will potentially further transmit until you can actually do all of that work. And so much of it, I mean, we were so close. We were down to eradication or elimination by 2030. People were having these really, Hillary Clinton, right, in World AIDS meeting and 2 years ago, was having, or maybe more than that, was having these conversations about we were almost there. And interestingly enough, this administration's at the State of the Union in, 17, he said, end the HIV epidemic. Brett Giroir said to him, we are going to end this HIV epidemic, and we were doing it. And we had focused counties that resources were going to in the United States. I don't have an answer for how we got here, why we got here. I do sort of plea that we have conversations. If people are not going to care about lives lost in foreign lands. I deeply care about that. I think many of us in this room deeply care about that. It will have manifestations. PEPFAR, among the reasons that PEPFAR happened is because of the global insecurity of losing a generation of people who are 30 years old. These will come back to haunt us. These policies will come back to haunt us, not just in lives that we let pass, but in many other global and political spheres. And if that's what's going to move the needle, then I would invite all of us to send those messages.
Rochelle, in Germany, we have an intense debate these days about an open and critical evaluation of our handling the corona pandemic. Has such an analysis ever been considered in the US?
Well, I will tell you, in April 2022, just as at the end of the Delta wave, I did one for CDC, and I said, look, many people are going to do this about us. We should probably hold the mirror up and do it about ourselves. And I think that one of the things, it wasn't very popular. I mean, you can imagine an agency that was downtrodden and had just been beaten through and was responsible for all of the work that happened in the couple of years prior, that then saying, okay, now let's talk about all the things that didn't go so well, was not that popular. Also, from an accountability standpoint, I felt like if we were going to regain the public's trust as an agency, we really needed to say, like, these are the things that went not so great, and these are all the ways that we are going to do better. So I felt strongly that we actually do one for ourselves. It took us several months. We interviewed hundreds of people from the White House to Congress, all the way, all walks of life. And we learned a lot. We learned about how we needed to move science faster. We learned about how we needed to, have different layers of guidances. We learned about our communication strategy, and that how we need to sort of say it in English, if you were, to be, to not speak science, but to speak to the American public. We learned about partnerships and how we weren't as good about partnerships. CDC had been known to be an academic agency, a place where science got published. I remember being in a meeting, and the scientists were around. There's some CDCers in this room, so I'll just. But I remember they had presented me these data on something, and they're like, "Well, this is going to come out in the MMWR," and I was like, "Great, when?" And they said 6 weeks. And I said, well, I'm going to say it at a press conference on Friday. So we're going to move this really fast because the American public needs to know. And so that was really among the things that I really tried to do, was get science out faster so that we could make decisions based on it. And the agency was engaged. They were excited to make that happen. There have been others. I know CSIS has done one. I know the COVID Commission has done one. I don't know if there's an appetite to do that again at a larger level. I think we have a lot to learn. I'm not opposed to the learning. Some of the retrospective scope doesn't take in all of the considerations that I think people in policymaking positions have to take into account. There is a component of the retrospective scope that says you didn't do the right thing, but not have the responsibility to say what the right thing would have been. And I used to say to the agency, which way are we going to be wrong today? Because there were only wrong answers.
So you did this proactively, and the report is probably available.
Mm-hmm. Mm-hmm. It's on our internet, yeah.
Oliver.
Thank you, Rochelle, for this enlightening lecture. And on this occasion, I would like to also thank the team at the American Academy to make these kind of lectures possible and creating this important platform. Question is, from your observation, which country's public health system has taken the most learnings from the pandemic and maybe also implemented these learnings best?
I'm not an adequate student of this to answer properly. What I will say, and I probably have more work to do in this space, but what I will say is the countries that handled the pandemic the best, who suffered the fewest lives lost, and who had sort of the most order in doing so, were those that trusted their government. So the ones that that would say if the government said, and you know, I used to say, well, if you're not going to trust the government, go to a trusted site, go to your hospital website, go to AMA, go to the American Academy of Pediatrics, go to some trusted site if you're not, and usually they're consistent with what the government was saying. We didn't go off the rails, you know, with any of these things. But really, like, trust is really an important component. And in America right now, that's pretty deeply lacking.
Sure. Thanks, Rochelle. It was a beautiful talk. Thank you. And I should have asked you this earlier, but it just occurred to me. So, because you talked about trust, I was at a meeting on trust in science in Boston with Francis Collins the other day, and he said something very similar. He said he wished when he had a 30-second spot to talk about anything that he would have taken the first 10 seconds to talk about uncertainty in what he was going to talk about. And I think I would love to know why you and he didn't. Like, is it that you didn't think it was necessary, that it's understood? Because the alternative is also that I think there's sometimes a conflict in public health between getting people to do something, persuading them, and informing them in a way that leaves open the possibility that they might decide differently because of the uncertainty, for instance. So I think sometimes uncertainty felt like something people avoided because they wanted to make sure people just get vaccinated. So if we want to do better next time, I think it's kind of important to understand why we didn't communicate the uncertainty. So I just wanted to... Yeah.
Can I leave that back to you and say we need media's help in order to do that? So, you know, if I'm doing a 120-second hit on NBC Nightly News, then I get I get pre-taped at 6 p.m. and it gets cut to 15 seconds, and they get the soundbite that they want, right? I don't really have a lot of control over those things. One of the fascinating things, and I talk about this, I have a talk that I give on communication and public health, but one of the fascinating things that this is like green Rochelle going into government, right? We did White House press conferences, and I did them for a long time. And then I realized, oh, these are White House reporters in the room. They're not even health reporters. And so I'm talking about incremental vaccine effectiveness studies and relative risk and all this. And I'm talking to political science reporters, and they're really good, but they don't know vaccine effectiveness.
We're political science reporters.
No,
they were just politics reporters.
That's a
big difference.
Sorry, I didn't mean political reporters.
Yeah.
And so you know, so much of what I say is like, know your audience. Who are you going to be talking to? And so, like, talking about managing uncertainty, like, first of all, that would have been the first thing that hit the cutting room floor. And it was never in your talking points for the weekend news shows. And so it never got what it really needed for the American public to understand.
If I can just add, having spent 10 years in government, uncertainty is not a government talking point.
Yes. I'm glad you said that.
Just, you know, if you are an elected official of the United States or someone with delegated authority, you know, getting up there and saying, you know, we don't know and our thinking's going to evolve is just, it may be honest, it may be correct, it may be where we should go, but it ain't where we are.
I was just at Harvard, and John was at a communication class, and they literally told them, whatever you say, never get up and say you don't know. And I was like, wow, I really thought we'd moved on from this. If you're trying to maximize trust, surely you have to say that sometimes.
Yeah.
More questions? All right, Adam.
Thank you for a great talk. Really instructive and lucid and humane, and just kind of building on or piggybacking on the question about trust. And I'm wondering, do you think that the delivery of public health, which is dependent on trust, is inextricably linked to democratic governance? Or could it exist in contexts where you don't have democratic governments, you have some form of authoritarianism? I mean,
I am no government scholar. What I do know is the footage that I saw from China in 2019, end of 2019, and that did not look like an easy way to tackle a pandemic. And so, yes, I actually do think that democratic governance, certainly if we can sort of extrapolate and say, trust is the countries that did the best trusted their government. And that trust happens in democratic governments. Then, and, you know, I think, I mean, can we command that shots go in arms? I suppose we can, but is that the best way to do it? I don't think so. And I think you have people who are evading, and so, yes, I do think so.
Is there a question? Yes, finally, a woman asking a question. It's been too long.
Thank you.
Thank you very much. So I wonder, like, do we know a lot about like the long-term side effects? Because what you advocate drugs or like vaccination, you only know approximately the short-term side effect. But do we know about long-term side effects, specifically, for example, HIV drugs? How does it affect our aging process and our cognitions, dementia, or for example, also like mental health? Some like people has HIV also have big problems of depression and substance use disorders. How would it affect them in this?
So you're talking about HIV, not COVID vaccines.
Just a specific example, but generally, how do we estimate this long-term side effect?
I think this is really a risk-benefit analysis that we have to do. So if people are dying of HIV like they were in those curves, you're willing to tolerate a lot of risk actually associated with not knowing what the long-term side effects are if you think that you can keep them alive. And in fact, there were huge protests that happened early on in days of HIV saying, the advocates and the activists were saying, we don't care what the long-term side effects are, we're going to die. So give us whatever you got and forget the clinical trials because we're about to die of this disease. And that was a lot of the advocacy that happened early on in the HIV pandemic. If then 20 years down the line, you have 3 or 4 other HIV antiretroviral treatment options, and they're all pretty good, then you actually do care about what the long-term side effects are, and your risk-benefit calculus changes over time. Similarly, with the vaccines, we know from decades of vaccination research that most side effects from vaccines happen in those first 6 weeks. We had extraordinary capacity to do vaccine surveillance, fortunately, in the United States. And I am sad about the 8 cases, but very proud of, or 6 cases, I should say, but very proud of the fact that CDC was able to detect 6 in 8 million cases of thrombotic events associated with the J&J vaccine. We knew about when we had 6 after 8 million doses were given, we could see that signal. So I think some of this is the risk-benefit ratio, and some of it relates to our surveillance and our capacity to do the studies.
Okay, we're going to squeeze in one last question. I'm sorry, we're coming to the end of our time, so wait for the mic.
Sure. I'll just make it quick because looking at the retraction of funds from the USAID and others, and on a global health scale, how do you see the role of public-private partnerships filling in some of those gaps?
The U.S. government isn't so great at public-private partnerships. They're very, very hard. And among the things that we learned in our review at CDC was how we had to do better. I really tried to promote some of those, and legally, they were really hard to do. It was really hard to get those to happen. So I think that they're going to be key. I am very hopeful that the public sector will help in spaces that they haven't helped before. I know that everybody, the private sector is going to be able, and philanthropic donations will help in areas that they haven't helped before. But I think everybody's going to feel the pinch, and so that everybody's going to be looking after both the private sector and philanthropic spaces. So I worry that that's going to be able to. I mean, I didn't show you a slide that talked about all the hiring freezes across universities, about the rescinding of PhD offers because they don't have the funds, about postdocs who can't get their positions. I mean, the entire scientific pipeline is really at risk right now, in addition to PEPFAR and USAID and all the things.
So would it be correct to say that if the U.S. has retrenched as much as we think it has, that the largest global provider of public health now is the Gates Foundation? It used to always be said it was the number 2, so
It could very well be.
that would be an astonishing thing.
Yeah.
All right. Well, not the happiest note to end on,
Oh, come on, let's talk about like.
but the potential is there.
Right.
All right. Well, we can.
And that you're awesome.
We can,